This program is brought to you by Emory University.
Hi, good afternoon, everyone. Welcome, everybody online. I think we'll slowly get some more people showing up, but it's a pleasure for me to announce today's speaker, Dr. Omer Inan, who I think a lot of us know because we've been working with him for a long time. But he did his master's and PhD in electrical engineering from Stanford. Um, not so long ago. And then he went into industry and worked there for a few years and then came back to Georgia Tech, where he's professor now. And his interest has been in devices for monitoring human signals in general, but particularly in those chronic diseases and in our line of business, particularly in things like heart failure, as you'll see. He's extremely prolific. He has won many distinctions and many awards. And he comes up with a device almost every year, so we have to keep inviting him back. Um, and one of the things that struck me is that he is also a shot putter, right? And so I thought that was
was a shot. Thank you. Thank you. Thanks, everyone. Thank you. Yes, he said is, but the true answer is was a shot putter there. All right, so let me get this stuff out of the way, hopefully. Yeah, great, perfect. All right, so thanks for those of you who are here, those of you who are online. And I'm just going to go through some of the stuff that we've been working on, and hopefully here you'll interrupt me. Online, I can't see the chat or anything, so if anybody has any questions, just jump in. I think we can. Where's my mouse? There we go. All right, cool. So these are my disclosures. There's a couple of companies. One of them is actually very relevant to what I'm going to talk about today, and that's CardioSense, which is a company that we co-founded in 2020 that's trying to commercialize some of the work that we've done that was funded through NIH and then Office of Naval Research, as well as CDC, that we're now trying to move into commercialization in the heart failure space. So that's obviously relevant. The device that I'm going to talk about is now being manufactured by CardioSense. And so that's obviously a relevant disclosure. So some of the stuff that I'm going to get into today, you'll see that our lab is very interested in things beyond electrophysiology and really getting into some mechanical sensing. And we're very interested in acoustics and vibrations. And so that's going to be kind of at the heart of, I guess, for lack of a better phrase, of what we get into here. And we've looked at actually joint sounds and some other things that I won't talk about today as well as a lab. And so this goes beyond just cardiovascular and pulmonary sensing. But overall, we're interested in these kind of mechanical characteristics because of the fact that they might be able to give us more information about hemodynamics and cardiac timings that are relevant to a variety of disease conditions. So I don't have to tell this group this, but the heart is a mechanical pump sitting in the chest that gets electrical signals, and every time it beats, there's actually these vibrations and movements of the body that can be sensed with external sensors. And it's kind of very interesting set of signals associated with that that's been studied for a long time. And our lab is kind of fascinated with these signals and trying to get more clinically relevant information out of them. This is usually, I do these sorts of fun little quizzes in these talks. I think in this room, this will be kind of a joke. You guys probably know exactly what this is, but sometimes people don't. It's possible that you won't. It's kind of an older picture, but do you guys know what this instrument is? I feel like probably with some of you, I should not allow you to answer the question. But do you know what this is? Yeah, that's a great answer. It looks like an instrument. That's yeah. So this is the first electrocardiograph, by Eindhoven. So it's a very good answer, very good answer. And basically these buckets were the electrodes, right, that he was using. And this thing is a string galvanometer. And I don't know if you guys want to discuss how that works, but we don't need to get into that. But that's the instrument of choice for the first recordings of ECGs. Okay, this one. Stuff going on. Stethoscope, yeah. So this is the first stethoscope, interestingly, from about 100 years before the ECG. And I didn't know this, but when I presented to the pulmonary group here, one of the researchers there, clinicians there, told me that the reason why the stethoscope was invented by Laennec was actually it was for reasons of social acceptability, where basically the male doctor putting the ear directly on the chest of the female patient was not considered acceptable. And so this is just an extension tube. It doesn't actually perform any acoustic action. This one, nobody should get this, but like I'm going to put this here. This is something called a ballistocardiograph table. So this is not used in clinical practice, right? So stethoscopes are ECG is this is a device that was built in the 1930s. Actually, around the same time as the ECG, there was a lot of research being pursued in something called the BCG, which is the mechanical movements of the body in response to the heartbeat. Some of the earliest studies that looked at heat stress physiology, study of a man in the desert, was actually done with Dr. Adolph. His book was actually done with ECG instruments in hot climates. And it was a tool that was originally a way to measure cardiac output non-invasively. And it turned out that there were some serious challenges with patient-to-patient variability and the ability to read out these signals. They wanted to use it the same way that you use an ECG, where you detect waves, the I wave, the J wave, mechanically with a strip chart measure the distance between the I and the J wave and try to relate that to cardiac output. Simple BCG. So this was a modality that basically in the 60s or 70s, after 30 to 40 years of pretty heavy research, was kind of abandoned when echo started catching on, and when you could basically just get some estimate of stroke volume through echo. And it was, of course, much more reliable. And so this was kind of put aside. In my PhD, I actually worked on a weighing scale to measure BCG signals. And since then, there have actually been a lot of commercial instantiations of BCG with various companies. The company Bedit that Apple purchased was actually a bed-based BCG. There's a company, Early Sense, that Hillrom purchased that allows you to measure BCG-based heart rate from people in bed. And so there've been and Withings, their kind of scale also uses BCG for heart rate, and they try to use it for PWV as well. So there's a lot of interesting BCG-based products that exist now that actually, when I was doing my PhD, nobody had even heard of this signal. Now, few people have heard of the signal, but at least there's some stuff out there. It's interesting. So we were actually heavily researching BCG signals. When I first got to Georgia Tech, my plan was I was already collaborating with clinicians at UCSF, Levu Klein, Teresa DeMarco, and the heart failure group in particular. Yeah. And my goal was to try to use this BCG-based scale as a home monitoring. Now there's that company they use in their scale, and kind of was to put these scales home with patients with heart failure and to try to remotely monitor their hemodynamics and perform some form of, at that time we were thinking, diuretic adjustment based on the fluid status. That was kind of the goal, right? When we did the early studies at UCSF, we noticed that a patient with heart failure standing still in a good posture on the scale is very difficult. They're frail, they'll move, they'll have kind of a slumped posture. It makes it difficult to transduce some of these signals. So around 2014 or so, we started developing a wearable device that would actually capture some of these same vibrations of the body, but from the chest. And our idea was, rather than using a scale, which really depends on the person being able to stand still on it, and we even tried having them sit on the scale. We tried building the scale into. We were going into this clinic in Palo Alto, actually, where they did CRT adjustment, and we actually took the little feet that held kind of the bottom part of the chair and the basically the patient bed, and we built in the strain gauges there to measure BCG signals while they were tuning the CRT parameters. This was when I was a student. We're just kind of going to Home Depot and like Fry's and stuff and buying some things to make it work. It was crazy, which was cool. Like we could see that as they were adjusting CRT, the timings and amplitudes of the signal you could see an optimal point where you got to maximize kind of beat out of it. But all of that was really dependent on the scale and the person's posture, and it was too much. So we really had to move to a wearable solution where you could get someone in a supine posture, or at least in a seated posture where they were still, and measure these signals. So we started with this. This was basically it's the size of an iPhone. It used 3 electrodes to stick onto the chest. So it measured the ECG. It measured what's called the seismocardiogram, or SCG, which is a sister signal to the BCG. It's just a local measurement on the chest. And we started examining how changes in hemodynamics might affect these signals. So just some simple stuff, like on top here, you see everything here is synchronized to the ECG R wave. So time 0 is when the R wave occurs. On top, you see the vibrations from normal heartbeats of a healthy adult. On the bottom, you see the mechanical vibrations ensuing from the PVCs that same adult had. And so with the PVCs, you notice that a couple of things, and this is just like, kind of some basic Wiggers diagram kind of stuff here, but basically you get a smaller acceleration of contraction for the PVC, and it's later in the cardiac cycle, is delayed because of the poorer contraction of the ventricle. And so this was some of the early stuff that we were observing, and then we decided to start both improving the hardware and taking measurements directly in patients with heart failure. So we went from this iPhone size thing on the left that was really kind of not comfortable to wear, to something that we called the hockey puck in the middle, which actually we did a lot of studies with. And then the most recent version of the hardware, that this was actually still developed in the academic setting, what you see on the right, but that's effectively now what's being commercialized by the company as the first product called CardioTag. So that's what we were using to measure these exact same signals. And in fact, we not only kind of miniaturized the hardware, but we actually added additional modalities to it, again, on the academic side first, where we added to ECG and seismocardiogram signals. We also added 6 channels of PPG signals that are measured reflectively from the surface of the skin. And this was a device, again, in the academic setting we pushed with NIH funding through the target of heart failure, but also with funding from the DoD because of their interest in trauma care and the potential for detecting hypovolemia and combat casualties, especially for long transit. And so they actually, ONR demoed this at the White House, at White House Demo Day in 2023 to the president as one of the technologies they were excited about, pairing with their automated critical care system that they're working on. So this is kind of what we now refer to as CardioTag, and we've done quite a few studies dating back to when I was a PhD student, even looking at these signals in the context of various hemodynamics. Maybe the most notable ones are, for sure, the most notable ones are the most recent ones. We actually, for the PCWP estimation, which we're doing now on the company side, we presented this at AHA at late breaking clinical trials. And also now we've found out just a week ago, and Dr. Kayumi is one of the co-authors there as well for his role on the Emory side, that this is now accepted for publication at JACC Heart Failure. So that'll be online pretty soon there. But a lot of the work we did on the academic setting set this up. And so most notable study we did was, we did the first study of linking these signals synchronously with right heart cath waveform data at UCSF. And so that was really a basic hemodynamic study where, for the first time, we examined the role of intracardiac filling pressures and the changes in these pressures and how they affect the signals measured in SCG and PPG from the chest. We also did work in 2018 that was focused also on patients with heart failure, but examining before and after they performed a 6-minute walk test to see how that affected the signals and to see if that could differentiate compensated from decompensated states, and a number of other studies focused on VO2 and stroke volume and these other kind of constituent parameters of hemodynamics. So our lab is interested in the hardware, but we've done a lot of work on the signal processing and ML side as well to be able to extract reliable information from these signals. So really what we specialize in is not just metadata, but the actual raw waveform data that we get from these patches. And that's that's kind of important to us. It's important to us for many of the applications that we work on. I think there's a lot of rich data in these physiological waveforms that's a lot of times lost when you just compress it down to heart rate variability, steps taken, and these sorts of metadata. And so I think what's exciting to us is to be able to quantify variability in the signals, to quantify signal quality by looking at the actual waveform characteristics compared to template waveforms that we've examined before, and to perform various algorithm development to reduce noise and extract information from these signals. So I'll talk a little bit about this study that really was the basis for us thinking about these signals as, for the first time, really as a means of assessing preload and filling status rather than just left ventricular performance. And this was basically a study that we did at UCSF. Right heart cath performed at the same time as the person is actually wearing the wearable patch. This is in patients with mainly HFrEF at that point, so heart failure with reduced ejection fraction. And basically, we captured the right heart cath in multiple chambers, starting with the right atrium, right ventricle into the PA, and then wedged into the sort of, with the balloon for the wedge pressure as well. And all of those waveforms we were measuring synchronously and concurrently with the waveforms from our hockey puck version of the patch. And at that time, we were actually thinking that we would specifically focus on changes in filling pressure. Again, the focus was getting this into remote monitoring, where we wanted to look at hemodynamics in patients with heart failure and examine if they're starting to, let's say, develop elevated filling pressures that could then lead to downstream decompensation events. So the idea was that we wanted to say, day to day, has the filling pressure, either PAP mean or PCWP, gone up? Has it gone down? Is it staying the same? And so what we did was we first looked at these patients and used a vasodilator challenge to be able to change their filling pressure and examine whether we could track that with the signals we were measuring. So with vasodilator, of course, PAP and PCWP in this population went down. As those went down, we also saw some changes in these physiological signals. We started examining not just the systolic component of the signals, but actually the diastolic portion of the timings. And since then, we ended up filing a patent application for that as well. That's now been allowed, so it's going to be issued pretty soon here by the USPTO on that. So the aspect of using these signals for filling pressures and specifically looking at diastolic timings to do so. We built some algorithms that were focused on trying to estimate changes in these filling pressures using a training validation set. This was, again, smaller patient population because it was a proof of concept at the time, just to say that we could track this change. And it did a pretty good job of that. I mean, we could tell that basically when the person's pressure was decreasing with the vasodilator, we would also track that it was decreasing. We could do this in both the training and validation set and also the few patients in the held out set. Early data, but the first data really showing that this was feasible and could be possible. So this is the only slide I'm showing that's actually data that was generated by the company, but this was a big study that the company did, CardioSense did, over the past year in 15 different sites, a total of 300 patients, 310 patients with HFrEF enrolled in the study, of which 265 ended up passing all the signal quality and these sorts of tests. 210 were used for development of a model to estimate PCWP, and then 55 were entirely held out validation set that was used to examine the performance on this held out set. And what was exciting for us here is that the error that we found was comparable to what you would see in a CardioMEMS or Cordella implantable sensor in the pulmonary artery. So this was exciting to us. Now on the company side, we're going into a pivotal study to try and demonstrate that we can do this on a completely new patient population. If so, we'll file at that time for FDA clearance. All of this is still investigational device, of course. Nothing is FDA cleared yet. So, all right. So then going back to this question of, what else can we do with this? So the heart failure population is one area we've been very interested in. At the same time, in about, I think it was around 2017, I was thinking about volume status kind of from another angle. And this was in discussions again with Office of Naval Research and some of the great program managers they have there that are really, that get you in touch with combat medics and you understand sort of the problem from their standpoint. And really the question is, if you can assess volume overload, what about the situation where you're kind of starving the heart of preload in the sense of hypovolemia? And whether that's absolute hypovolemia in the sense of hemorrhage or dehydration, or whether it's relative hypovolemia where you may have severe vasodilation at the periphery, leading to a greater capacity being filled by the same volume of blood. In both cases, you're reducing the preload to the heart, and you have sort of a basically greater stress on the heart that ensues. So with Jino Han from University of Maryland, my close collaborator and friend there, who's a mechanical engineering professor, we've been working on this problem for the past several years. And our ultimate kind of aim that we're trying to head towards is to be able to use wearable device with real-time volume status assessment with our algorithms to then be able to make triage as well as resuscitation decisions and possibly even tie this into a fully closed loop system. There's many challenges to get there, but it's a very interesting research problem that we've been working on. And in fact, there's so little that's known in how hypovolemia can affect these signals that we had to really go basic here with the studies and actually start with a pig model at first. And so what we did was we had pigs. The study was done at T3 Labs back when that was a Georgia Tech facility. Now it's Verinex, but basically we had six pigs. We had both a relative hypovolemia and an absolute hypovolemia portion. For absolute hypovolemia, it was volume depletion, where we sequentially decreased the blood supply through bleeding out, basically the pig, until we got to the point on both the relative and the absolute side where we saw a decrease of 20 millimeters of mercury in mean arterial pressure, which indicated that they were decompensated. And then we'd go to volume replacement. And the goal was basically we had catheter data measuring aortic pressure, actually femoral pressure as well, cardiac output, not continuously, but basically with thermodilution at each of the levels of volume depletion. And then we also had our non-invasive sensors at the same time. And so what we did was we took the actual, the point at which the pigs decompensated, we considered that 100% blood volume decompensation status. That's where they decompensated. And then at each interval where, let's say, some percentage of blood was decreased before that, that was 25%, 33%, depending on how many intervals there were. And then on our wearable side, we tried to build an algorithm with the non-invasive signals that could also estimate volume status and then compare against basically the ground truth. And so when we did that, we had reasonable, monotonic increase in volume status going from kind of a good state, compensated state to decompensated state. And maybe most importantly on the ROC curve for being able to classify compensated versus decompensated, we had a good area under the curve there as well. And what was interesting here is we also looked at which of the signals and which features of those signals were most valuable in understanding volume status in this hypovolemia state. And we found that the SCG and ECG signals were the most important ones. The PPG provided some value as well. But this is important because it says that looking at, for example, heart rate alone or blood pressure alone, or some of these typical vitals that can be measured were not as predictive of volume status as actually the mechanical timings, how long the heart is spending in isovolumetric contraction versus systolic ejection, and kind of the ratio of those two. So the longer it spends basically building up the pressure to eject compared to the time it actually spends ejecting blood is kind of one of the most important parameter that was found to assess the volume status at that point, which makes sense. There's old literature dating back 30, 40 years that says that that's kind of an inverse, that has an inverse dependence on ejection fraction. So this was kind of an interesting study. The other thing that we found that was important, there's other work out there that's being done to address this problem where people measure PPG signals alone. And PPG, of course, is a peripheral signal. And so as you get to really low volume status with a lot of blood volume loss, and this is in basically one of the pigs here, the PPG signal starts to completely disappear. Basically, you don't have a peripheral pulse that can be measured accurately. Whereas with the SCG, we were still able to measure the signal all the way down to very low volume levels because the heart was still moving, blood was still being ejected from the central source. So kind of important, I think, to have both the central and peripheral information there. This is now some work we've been doing more recently with Amit Shah, also from Emory, where we've been sort of examining the PPG signal on the chest and looking at different wavelengths of PPG. And the idea here is really there's very little that's understood from the literature we found on the, PPG is usually measured the fingers, the earlobe, the toes, maybe the forehead with reflectance devices, but on the chest, it does different things. Like in these different stressors, I'll present a little bit later in this talk, but with different stressors where the finger may vasoconstrict, the chest PPG vasodilates, like stress, for example. And with respiration, as you go to basically more resistance, like a greater resistance respiration, same thing. PPG on the chest, you see sort of a vasodilation kind of effect, a greater signal. Fingers, you see a smaller signal. So we're trying to understand, for the first part, what wavelengths have the best signal quality at the chest, and then also how does the signal behave? And so we've been working on this with some studies at Georgia Tech, just healthy population, but trying to understand the various dependencies. Getting into some of the engineering details here, but one of the things that's been important to us is dealing with motion artifact and external vibrations. Part of this is because of the fact that we're interested in studying these signals, not just in the clinical environment, but in remote settings. Could be the home, could be also in sort of a trauma care setting in the field. And in those settings, you're going to have motion and vibration. So we've done a lot of work on both creating simulators that in software can simulate the noise and also hardware that can simulate the signal. So we have a phantom generator of SCG and ECG signals that we're able to take into relevant environments, for example, on a military vehicle. And so there's a mannequin with our synthetic generator of SCG and ECG that can go on board a military transport vehicle and basically have the SCG and ECG ground truth while it's experiencing all the vibrations. And then we can look at our algorithms to see how well we can remove those vibration artifacts, knowing what the signal should have looked like. We also have synthetic generation of the signals themselves, which we use to feed into those situations so that we can have, what if it was a person with various physiological stressors or various changes in the, underlying physiological timings, how does that affect things? And then we work on sort of the noise rejection from there. I'm going to get into some things that are more focused on pulmonary sensing, but I think you guys might find it interesting. And I think bioimpedance is also used, of course, for impedance cardiography and plethysmography and all this other stuff. So I think you'll find it interesting. But we've done a lot of work in the lab on trying to build better hardware and also algorithms for wearable multi-frequency bioimpedance sensing. And one of the things we wanted to use this for has been to expand from just cardiovascular sensing alone to also examine cardiopulmonary and specifically tidal volume, respiratory timings, and also the interplay between, of course, the cardiovascular signals and these pulmonary timings. And so what we've been trying to do is normally there's a signal impedance tomography that people measure where you put electrodes kind of on the side of the chest and the neck, similar to impedance cardiography. And so we've been seeing, what if you actually just put these in a constrained location that could actually be built into the same hardware as cardiovascular sensing. So you kind of put a patch on the chest and it measures both the, hemodynamics, let's say, as well as respiratory mechanics. So that's kind of the direction we've been trying to go with this. We did a lot of work on the system that had, many different things going on, basically, where we were measuring these impedances together with actually 4 lung sound measurements as well, temperature measurement. This was an interesting device that actually started as a system we were using for knee health. And then during COVID, we decided to use kind of a COVID supplement to see could we use these same signals in measuring cardiopulmonary parameters. We ended up doing some studies actually at Grady with the system. So these are some simple like inspiratory crackles here, but in the paper, we also talk about Shane Stokes breathing patterns in patients with heart failure and looking at from admit to discharge as the fluid in the lungs and the chest kind of decreases through diuresis, how we can examine those changes with the system as well. But it was basically a system to get us to better understand how lung sounds could be used together with bioimpedance to feed into broader monitoring of pulmonary uh, fluid status and physiology in clinical settings. This is still in review, but we did the study with Jocelyn and Kevin here at Emory and Children's and kids with asthma that were with acute asthma that were in the pediatric ICU. And here again, the scientific goal was to understand the interplay between bioimpedance-based markers and lung sounds that we were measuring. So on the left here, you see continuous abnormal expiratory sounds from a patient. So every time you can see with the impedance on top, can I point like this? Yeah. So in the impedance on top, you can see when they're inspiring, when they're expiring, based on the changes in chest impedance. And this is measured basically with that system that I was showing here. And then every time there's expiration, you can see actually some sounds. And this is the spectrogram. So you're seeing actually the frequency content of the sounds in sort of the hundreds of hertz range during the expiration, as you might expect during asthma. This is an EKO stethoscope, basically, that's FDA cleared that we're using to compare against with our device. In the middle here, you see expiratory wheezes from a 3-year-old patient when they're admitted, and then normal sounds from the same patient at discharge. So we did a lot of analysis with this, actually quantitative analysis as well. Again, this is still under review, but an interesting way to examine the interplay between these sounds and bioimpedance. We also did a study in just one pig, but where we were examining different levels of fluid, pleural effusion in this case, in the pig model, and seeing how that affected the multi-frequency bioimpedance sensing in the chest. And could we see basically changes proportionally in the bioimpedance as you increase the fluid in the pleural cavity? And we did. And basically, at this point, we were also examining the way that kind of things, you could see there's like a shift of uh, things that occurred basically once we got to a certain level of fluid at around 825 milliliters. There's some kind of other stuff that's going on basically with the chest. But this was kind of an interesting result. Again, various things we want to sort of measure at the chest. And we have a new device we're working on that I'm not presenting here, but that kind of combines those things into one. This was some recent work we did. So we've been interested for a while here. We've done some studies with Doug Bremner, with Arshad as well, Kayumi as well, and Viola Vaccarino and Amit Shah. And I'll talk about those in a little bit, but where we were very interested in assessing the acute responses to stress, mental stress and traumatic stress in patients with PTSD. That's kind of what started our interest in using these signals as autonomic markers. Um, and that basically came out of some work where we were also interested in reducing the acute physiological responses to stress with non-invasive peripheral vagus nerve stimulation. So with all of that, we started getting interested in other populations where there's dysautonomia. So with Dr. Paul Beach here, we performed some studies that we just published this year in patients with Parkinson's and multiple systems atrophy that had orthostatic hypotension, as well as those that did not have orthostatic hypotension. And we used basically this patch to measure the various different electrical, mechanical, and peripheral vascular markers and waveforms from these patients as they performed in the clinical setting, a supine to standing postural shift. And then also we sent the devices home. So this is actually the first population where we sent these devices home for a 24-hour period for continuous recording to try to examine in the home setting, could we detect when they did an orthostatic transition? And when they did, could we see the changes in physiology and did they kind of mirror what we saw in the clinical setting? And some did, some didn't. But so I'll talk about some of this. So in the clinical setting, we could see very clearly with no OH versus OH, orthostatic hypotension versus not, in both populations, you see this time series change in features of these physiological signals that's evident. And so, for example, like heart rate is a simple one. For no OH, you see a greater increase in heart rate going from laying down to standing up. It makes sense. For OH, it's kind of a slow response and not as big of a change at first. These are some other kind of vascular timings, PPG amplitude. Also, we see differences, PEP over LVT. So various different signal characteristics combining the electrical, mechanical, and vascular signals we see differences in the populations. And this is aggregated across the full population here. What's interesting is this is now looking in something called principal components analysis, where basically we're taking all the data that's reported and kind of making it into a lower dimensional space where we can examine the trajectories. Kind of a way of looking at dynamics in response to these transitions. So for the clinical test, you look at no OH versus OH, and there's a pretty clear difference. Basically, the yellow trajectory is no OH, the red trajectory is OH. And so they're kind of going in different directions. This is averaged across the patient populations. For the at home as well, now this is one where we have no ground truth, right? We don't know for sure that there was an orthostatic transition. We don't know anything else about their physiology, but it is clear that every time we're detecting just from the accelerometer that this transition occurred, which we're pretty certain of because it's an acceleration change with gravity that goes from laying down to standing up, that's pretty clear, that the physiology also has different trajectories in the home setting. So where this could be interesting and useful, and we're talking with Paul about next steps on this now, is what if we have patients where you don't know yet, like they have Parkinson's, maybe early stage, and you don't know if they have yet autonomic, dysautonomia of any sort, and you send the device home over some period of time, and you start detecting that their trajectories in response to these orthostatic transitions start to look more like a OH kind of candidate, and then maybe you observe them more carefully. Of course, the issue is if they have OH, they can get up, get dizzy, and fall. And, in this population, that's a major issue, of course. So we've also been studying these same signals from the device in response to stressors. So this is basically a mental stress challenge. And we have quite a bit of data on this now with what's called the MIM study that we're examining more closely with this group of collaborators here that you see. And basically, one of the things, so there were things that were expected for us in these responses, in the stress responses, like in the heart rate, decrease in heart rate variability, decrease in pre-ejection period, all of that is expected decrease in PTT. What completely surprised us was we saw an increase in PPG amplitude. And in every other study we've done, like with Doug, we had this nice study we did in PTSD, where actually one of the best markers of acute stress and then the resultant actually improvement in the reduction of acute stress response to traumatic stress with VNS was that PPG amplitude would decrease normally and didn't decrease as much when you did VNS. And so this was surprising to us. So this is where we first started trying to understand this better. There's a lot of stuff going on this slide, but basically this is still under review. We'll see how much this changes. But very interestingly, we've been finding that there is actually, you can, even in healthy adults, when you perform various physiological stressors, you see kind of a difference in the way that the finger versus the sternum or core body PPG change in response to the stressor. And maybe that's an obvious thing. We haven't found literature on it. So to us, it's not obvious. And it actually does explain what we're seeing in the mental stress case. And there's definitely no literature on this. I mean, unless we miss something, but I don't think there's any literature on this. So it's quite interesting because it means that, what are you measuring then? Is it basically the increase in blood flow to the intercostal muscles in the chest associated with more effort and breathing? Because here in this study, we actually did resistive breathing, which is one of the more interesting results, right? With resistive breathing, the finger PPG decreases in amplitude by almost 50%. The chest PPG increases in amplitude by 30%. That's an interesting one to us, right? And so is it basically during stress, is it the increase in breathing effort, active expiration, for example, that's leading to the increase in PPG amplitude? We were thinking maybe it's an increase in blood volume to the core, but then when we do some of these postural changes, it doesn't seem to be the case. So it's pretty interesting to us. Still something we need to study more, but at least some of the original findings that we have seem to point to breathing variations being the cause of this, which would be super interesting in the acute stress kind of measurement side of things. This is just an older result, but interesting, like where it's interesting to us, like looking at different types of stressors and how it affects the physiology. And there's great background physiological literature on this from Karen Quigley at Northeastern. And so like this is not a surprising finding, but it's cool that from the wearable we see some of these things that normally would require echo or impedance or other modalities to get at. I mentioned this result over and over again. Probably should have had the slide earlier, but but through the DARPA Electrics program, Doug and I did these studies. Well, we didn't do anything, our students and trainees did it. Doug did more than I did because he was, actually there with the patients. But, we as a team performed some studies in patients with PTSD as well as non-PTSD trauma controls and demonstrated that in the physiology, you could see differences through this non-invasive stimulation through the gamma-4 device in the active group compared to sham that indicated that actually you had a reduction in sympathetic arousal in that group. And this was important. And actually, some of these results that I'm showing here led to basically that company, ElectroCore, which we have no part in this company. They just used this data for their basically submission to the FDA that led to their breakthrough designation as a device for PTSD symptom treatment. So that was exciting for us, of course. So basically with that, I want to talk about some future opportunities, but there's a lot of these. I mean, there's just a couple that I noted here. As I mentioned, triage support is interesting to us. Better ways of assessing autonomic state and reactivity in the context of stress and other disease states as well. I think this is a really interesting area. A lot of people have focused on HRV. It's not very specific. It's, like you want, I think, better measures there of these quantitative parameters. And I think there could be some interesting things there. I didn't mention our work on pediatrics, but we've done some work that was at that time in collaboration with UT Southwestern. Now the investigator we're working with, he's a Cleveland Clinic. We're still continuing that work, but we're very interested in especially low cardiac output syndrome detection and prediction in kids through some of these technologies as well, smaller versions of the wearable sensor that we're working on as a lab. But with that, I'd love to take some questions and thanks for inviting me to be here. Should I stop the share so I can see videos, or should I leave the slides?
They must be able to see us.
Oh, that's right. Yeah, that's true. Here, let's do. Here, I'll do this. There we go.
So you can
I guess no one's on video. All right, so I could have just. All right. Anybody have questions online? Or in person, obviously.
So come on, I can start. Lots of stuff. I mean, goodness, what a venue.
Thank you.
I remember the edema device that you were using in the lung during COVID. Was that similar to what we were doing in the ankle and detecting edema and then trying to predict?
Yes, it's the same bioimpedance, although it's improved now. Like the newer one's a little bit better than that. And we've worked with the electrode technologies as well to make them a little bit more flexible and where it could be like in a single patch. So, but it's a similar core technology, and we did get good results there as well. Yeah, with the ankle. So I think that's something that could be, it could be a better form factor, I think, than what it was then with the one now. And I think the performance of the bioimpedance is better than that for sure.
So do you think that's something to pursue as like edema detection that some of the part failure?
Yeah. I mean, it's interesting. We could for sure. From a device standpoint, it would be a question of what's the best form factor to allow it to be used easily, but it could be something that could be pursued. I wonder the chest one, but it's not going to be peripheral edema. Of course, it's going to be edema in the chest. But yeah, I think that could be super interesting.
The other question was regarding the confusing results that you said about the restriction in the finger, but dilation on the other muscles.
Yeah.
So I guess during exercise, muscle blood flow goes up,
Mhm.
right? And And during mental stress, we think that it goes down as you constrict to a varying extent, but more or less, most of us will constrict to a certain degree. And most of the data that we got was from this PAT device.
Yes.
Just looking at trigger pulsatility. And it's looking at small muscles in the fingers, I think. Maybe some scale, but maybe much still. So I wondered what's different about the muscle, where you actually see often. And is it more to do with innervation, that the innervation to the chest wall muscle is similar to skeletal muscle, but very different from small muscle groups? I don't know.
So it's a great question. So the question was from Dr. Koyumi on basically the why, at the periphery and let's say your skeletal muscles and your arms or your legs, likely you get vasoconstriction with mental stress because the blood is kind of routed elsewhere. But in the chest here, we have the intercostal muscles. Why would they get more, and I guess for us, we were wondering, we know that respiratory patterns. So we've actually published also with Doug on how respiratory rate and variability during these stressors changes pretty dramatically. Especially in PTSD, we found that basically the respiratory rate variability was one of the big findings, and we could basically link it to actually some of the brain imaging work as well. That's kind of like it made sense that basically you'd get different respiratory variability patterns. I'm not even going to go into what regions of the brain. That's a question for Dr. Bremner that somebody else can ask him. But basically, I think my understanding is if expiration is rather than a passive event based on lung compliance, but now actually you're engaging the intercostal muscles to do active expiration, then that could be the source of the increased blood flow, I think, and vasodilation to those muscles. That's kind of what we were thinking, and that's sort of what this result shows because, let's see if I can, because when we look at oh, come on. There we go. When we look at resistive breathing, in this case, nothing else is changing except the person is breathing through a resistance. And so we know that they're having to actively decrease more interpleural pressure and work harder to push out the air than they would normally. And in that case, we get a decrease in the finger, we get an increase in the chest. And so that's, that seems to point in the direction that you're getting an increase in blood flow to the intercostal muscles. We don't know this for sure, of course. Like we don't have imaging data showing that, but it would be interesting to do a more thorough study, I guess, to see.
This is a finger device that you're using here.
For the finger? Yeah. We're just using like a commercially available device for that. I think it might just be the BioPack device of the finger. Yeah.
Very nice talk.
Thanks.
So just so I understand, because this may be a really silly question, but there's, in the body, you've got the electrical signals that are coming from the nerves. Then you've got the mechanical, movement of the body. So these devices, are they able to tease out, like if I'm sitting perfectly still, or if I have an increase in pain, will it pick up nervous signals related to pain compared to like when I'm not in pain versus when I'm in pain?
Not in the way that so the mechanical signals are coming from the heart's actual pumping and movement of blood. So when you're in pain, if you see an increase in sympathetic arousal, then we should see a decrease in the time interval between the electrical event, the R wave, and the opening of the aortic valve. I think that would be the expected, the hypothesis, that could be confirmed. There's probably literature on it, actually, but that would be the expectation. So similarly, like it with the patients with PTSD or trauma controls, if they're exposed to a traumatic stressor or mental stress, we see sympathetic arousal leading to the decrease in the time interval between the R wave and the opening of the aortic valve. Basically, that electrical to mechanical delay. So I would expect that we would see a difference there. But it's not due to like the pain causing movement of the body. That's separate. Like there could be restlessness and this kind of thing that may also occur, but this is just the mechanical contraction of the heart and the timing there from cardiac sympathetic activity.
Dr. Berner says it's the amygdala.
What is it?
Amygdala.
Amygdala. Excellent. Thank you. Thank you, sir. Thank you.
So we measure the years for loud. So are we actually measuring movements or are we actually measuring what's
Bioimpedance. Right. So impedance of like the chest, impedance cardiography. It's it's an electrical signal, but the reason why the electrical signal is changing is due to mechanical movement of blood. So the mechanism that is being measured by impedance is the mechanical, it's hemodynamics. It's the movement of blood. Blood is more conductive than everything else in the sort of chest. And so as the blood volume in the chest changes due to aortic flow and the blood going elsewhere in the body, that leads to a decrease as the blood leaves, basically increase in impedance. Blood comes back, a decrease in impedance in the chest. So it's an electrical signal, but it's measuring a mechanical event. So the tachycardia itself will change. So the impedance also, you get one pulse every time you have a heart. So you can see the heart rate. So if you have tachycardia, you'll see an increase in heart rate. But also likely, if you have tachycardia, maybe you get, short term, maybe you get less filling uh, because you have less kind of RR interval prior to the beat. So maybe you'll get reduction in preload, maybe. But then also maybe with tachycardia, you get an increase in sympathetic tone, and so you get an increase in stroke volume, in which case it may go the other direction. But like the tachycardia itself is not what you'll see an increase in heart rate, but how that affects the hemodynamics, depending on how it affects the hemodynamics, you'll see a difference in the mechanical aspects of the signals. Yeah. So that's where it's different than the ECG, right? With the ECG, you'd see that the heart rate's faster, but you wouldn't necessarily know, like you can't look at the QT interval and guess what the stroke volume is or anything like that. Okay. Well,
Very much.
thanks so much again. Thank you. Thanks, everyone.
The preceding program is copyrighted by Emory University.